From the American Academy of Pediatrics.
COVID-19 remains a serious threat to children's health, causing hospitalizations and even deaths.
A new policy statement updates the recommendations for COVID vaccines in the pediatric population.
We've been looking at when would be the right time to switch from, if you will, universal, recommended for everyone, to risk-based. And that's really what this policy is the culmination of all of that review.
Plus, we'll look at the use of buprenorphine for the treatment of opioid use disorder in young people.
I really would encourage listeners to consider this as being sort of routine and standard evidence-based care, not something that is specialized or niche or requires everybody to be referred out.
These stories and more on Pediatrics on Call, a podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a look at recommendations for COVID-19 vaccines in infants, children, and adolescents.
Joanna, with all the controversies and breaking news we cover on this podcast, do you ever wish we could just kick back and talk about something routine and boring?
I mean, yeah, that would be nice every now and then, but I've come to find nothing is routine anymore, and things I thought were easy to discuss have become more challenging. Did you have a topic in mind, David?
I do. It's perfect. Just a thing that comes up every year now.
What is it?
Updated guidance on COVID vaccination for children.
The lightning rod of vaccination for pediatricians to talk about. I don't think this is going to be that chill episode you wanted. The AAP did just publish recommendations for COVID-19 vaccines in infants, children, and adolescents. That will be a good place to ground ourselves in this thunderstorm.
And that is why we booked Dr. James Campbell, professor of pediatrics and interim head of the Division of Infectious Diseases and Tropical Pediatrics at the University of Maryland School of Medicine, as well as vice chair of the AAP Committee on Infectious Diseases. Jim, welcome.
All right. I'm glad to be here. Nice to see you, David and Joanna. Glad to be here.
Thank you so much for joining us today. And to start, David and I alluded to the fact that the COVID vaccine has become, I guess the right word is divisive. Why? What makes this vaccine more charged than others?
Oh, boy. There's a number of different things, but probably the primary thing is that it's a new vaccine platform, as we call it, meaning it's the first licensed mRNA vaccine that we've had. That's part of the divisiveness, if you will. Some people believing that Operation Warp Speed went too much at warp speed and that they moved faster than usual vaccine studies. I think there's also the issue of early on in the pandemic, everyone talking about the difference in how severe the disease was for children versus adults, and then believing that we shouldn't be vaccinating children because they didn't have as severe infection as adults. I think those, and just, there is a fair amount of fatigue, as people say, like vaccine fatigue with new things coming on the market. So I think the coming together of all of those have led to it being a bit divisive.
Well, let's get to this policy statement. It is short, but it's packed with detail. Can we break it down, starting with the youngest children, those ages 6 months to 2 years? What are we recommending?
Sure, love to. At the very beginning of the pandemic, and once we had vaccines available, we recommended them for everyone. And then over time, more and more people are infected and have been vaccinated. And so fewer and fewer people need to get the vaccine. So over the last year and a half, we've been looking at when would be the right time to switch from, if you will, universal, recommended for everyone, to risk-based. And that's really what this policy is the culmination of all of that review. So if you're under 6 months, which is not in this policy, we don't have a vaccine that's licensed for that age. What we have are vaccines for moms who are pregnant with babies. And if they get vaccinated, they will protect their babies in the first 6 months of life. So that's how we protect under 6-monthers. And those are the kids at highest risk of hospitalization. And then between 6 months and 2 years, children typically have not yet had COVID, and they are, after the first 6 months of life, that's the next highest risk by age for them to be hospitalized. And their risk of hospitalization is similar to older people, people that everyone thinks should be vaccinated. And then after that, once you get above 2, then we're recommending those who are at high risk for us to push for them to be vaccinated. And if they live in a household with somebody at high risk, if they live in congregate settings, things like that. So it's kind of like high risk based across all ages. But for the youngest, their age itself is the high risk condition. Most of the kids hospitalized at that age, they don't have underlying comorbidities like, older people.
And is this essentially the same thing that the Centers for Disease Control and Prevention are recommending?
No. So CDC uses, of course, an advisory committee, the Advisory Committee on Immunization Practices, to help to make their recommendations. And what they have now recommended is that all COVID vaccines for children be given under what's called shared clinical decision-making. So discussing with your provider, with your pediatrician, with anybody who cares for the child, including potentially a pharmacist even, to discuss with them whether or not it's right for the family, but not based on high-risk conditions or specific ages.
Well, I really like how the AAP has used evidence to support their recommendations. And some children should be getting 2 doses of the COVID vaccine instead of 1. Who needs that second dose when they get vaccinated?
Yeah, so it's the first time that you receive COVID vaccine that you need to have what you might call now the primary series. So the 2 doses of the Spikevax Moderna vaccine for the 6-month to 23-month-olds. And then subsequent, it's single dose. Also for children who have immune incompetence, so those whose immune systems might not respond so well to a single dose, they need to have the 2 doses. So I think for both families and for pediatricians, an analogy that you could use would be something like pneumococcal vaccine. So, we give pneumococcal vaccine to the youngest children, full series. Because of their age, they're at high risk of invasive pneumococcal disease. Who do we give it to after that age? After you're a toddler? Only those who are at high risk, children with sickle cell disease, children without a spleen, et cetera. So it's similar, you can kind of analogize here is that the young age, they need the primary series for COVID vaccine. They've never had COVID before. They're at high risk of hospitalization. And then as they get older, it's based more on their risk or the risk of those around them.
So, Jim, you mentioned some difference between the AAP recommendation and this shared decision-making recommendation from the CDC. The policy statement that the AAP put up says anyone who desires protection from COVID in that age group of 6 months to 18 years should get a dose of the vaccine. How meaningful in practice is this difference?
We wanted to allow for parents, guardians, families to have their children be vaccinated, even if they didn't fall into a high-risk category. So how different is that? The technical meaning of shared clinical decision-making at the ACIP and the CDC level is that it's not a vaccine that is recommended. It's a vaccine that should be discussed. For us, we like to make full-on recommendations. We know that pediatricians for all medical advice do that in a form of, in the vernacular, a type of shared clinical decision-making. We make decisions together with the families that we care for. That's a little different than this sort of technical term of shared clinical decision-making at the CDC. It's not just the Webster's Dictionary version of it. It has a different meaning, really.
I know pediatricians spend a lot of time counseling and talking about vaccines, and I think they're all accustomed to the flu vaccine being an annual vaccine, which changes every year because of the way influenza virus drifts and shifts over time. Is that the same thing we're looking at now with SARS-CoV-2, or is the process different?
I think, Joanna, it's a little early for us to definitively say whether or not the recommendations will be exactly like flu vaccines have been in the past. By that, I mean whether or not we'll have annual seasonal updates. It looks like SARS-CoV-2, the virus that causes COVID-19, is going from pandemic, epidemic to being another endemic coronavirus. We have 4 other coronaviruses that typically give kids just colds, started a long time ago as pandemics and over time switched to endemic coronaviruses. They jumped from animals to people. So it's likely that's what's going to happen with SARS-CoV-2. We don't know whether, like for flu, it will change enough each year for us to have an updated version every year. So far, that's been the case. Or, it could be even less than a year that it changes that much. But it's going to take a little time before we know how frequently the strain type will have to be changed in the vaccine.
One issue that seems to keep coming up when we talk about the COVID vaccine is myocarditis. Can you remind us why this is and talk about the risks with and without the vaccine?
So myocarditis, as you both know, and hopefully most of the listeners would know, is a inflammation of the muscles of the heart. And during the studies of the COVID vaccines, there were no cases of myocarditis because it was so rare. Those studies had tens of thousands of people in them, but it took millions of people getting the vaccine before it was discovered that there was an association. It's primarily seen after the first time that you get the vaccine and primarily in boys or young men and not girls or young women. So between maybe the ages about 15 and 25. It's quite a rare problem after the vaccine. And most of the time, even though it is muscle inflammation, in the heart, is not as severe as some of the other myocarditis that we see, like after various types of viruses, including SARS-CoV-2. So myocarditis associated with the infection can be very severe. Myocarditis associated with the vaccine is rare and not so severe. And it's become less and less common. So it's been reported on by the CDC and others who've been following this throughout the pandemic, and more cases earlier on in the pandemic associated with vaccine than later on. And not only because fewer people were being vaccinated, but among those vaccinated, fewer getting myocarditis. So it is a problem. It's a rare problem. We as pediatricians are used to counseling people to say, every once in a while, but very rarely, a child may have a severe allergic reaction to a vaccine. It's around the same order of magnitude as that sort of problem. So, people should know that there can be very rare problems associated with vaccines, and they're not without risk, but rare risks.
And when we talk about vaccines, which formulations are available to parents and pediatricians, and is one version better than the other?
So the Food and Drug Administration recently changed from emergency use authorization, the way that we had these vaccines licensed for children all through the pandemic until now, to full licensure. But there's different age cutoffs for the licensure for the different vaccines. So the one that's made by Moderna, the mRNA by Moderna, Spikevax, is licensed down to 6 months. The Pfizer vaccine had emergency use authorization down to 6 months, but it's only licensed down to age 5 years. And then the 2 other vaccines are only licensed from 12 years and up. So it's different vaccine formulations or manufacturers that are available for different age groups.
And how are you framing this advice for parents now? Are there better ways to talk about COVID vaccine that you think are particularly effective?
I think one of the main things that we can do is to try, and we've been trying to do this from the beginning of the pandemic, but it's been an uphill battle, and that is to reframe what we compare COVID to when we talk to parents. If you compare COVID severity in children to COVID severity in grandparents, it's an unfair comparison. And we never do that with other pediatric problems. We tend to compare pediatric problems with other pediatric problems. So like how severe is COVID compared to influenza, or how many people are being hospitalized with COVID in children compared to other things. So for example, for influenza, unfortunately, the same number of children last year under 6 months of age who died from flu died from COVID. So in the news, everyone hears it's not a problem in children, but it's as big a problem in children, especially the youngest children, as, for example, influenza is. During the pandemic, COVID was among the top 10 causes of death in children throughout the time. Not now, but it was back when the pandemic was going on. Was it the top 10 causes of death among all people in the United States? No. But children don't die very frequently. So being in the top 10 causes, the other things, as you guys know, are in those top 10 causes are things like car accidents and gun accidents and suicide and things like that. So it was a severe disease. It still can be a severe disease. And so 90% of children who are hospitalized with COVID are unvaccinated. I have not ever, we're now, in the 5th year, I work at a pediatric children's hospital. I have never had a patient I've cared for in the hospital with COVID who was vaccinated. Never, not one. But 90%, if you look at across the country, are unvaccinated. So COVID vaccines at this point don't prevent so much colds and minor COVID illness, but they do keep you out of the hospital. They do keep you out of the intensive care unit. They do keep you off of a mechanical ventilator.
I hope that every practicing pediatrician will bookmark this policy statement and refer to it often. But in the meantime, can you leave us with one takeaway for our listeners?
The one takeaway I guess I would leave with you all is COVID-19 vaccines have been extensively studied. They are as safe as all of the other vaccines that we recommend. And they are effective in preventing especially severe COVID, long COVID, MIS-C, all of those problems. So encouraging families to get COVID vaccine for their children, we as providers, I think we'll feel better if we are pushing families to get their children COVID vaccinated because it'll keep them out of the hospital.
Well, Dr. James Campbell, thank you so much for talking with us today.
You're welcome. Thanks for having me.
To read recommendations for COVID-19 vaccines in infants, children, and adolescents policy statement, visit us at aap.org/podcast.
Coming up, we'll discuss the use of buprenorphine for the treatment of opioid use disorder in young people.
Opioid use disorder can be difficult to treat in young people. There just aren't a lot of medications that are recommended for use.
I have noticed that the treatment for opioid use disorder can vary for, say, pregnant women who are giving birth, but for young people, less than 18 years of age, the only medication approved by the FDA is buprenorphine.
And we still have a lot to learn about how this medication helps our pediatric patients.
Well, there is one person who has talked about opiate use on the podcast before and is passionate about education on its treatment, and that's Dr. Scott Hadland. He is the first author on a new paper in pediatrics, Buprenorphine Treatment Duration and Adherence Among Youth and Subsequent Health Outcomes.
To remind our listeners, Dr. Hadland is the chief of adolescent and young adult medicine at Mass General for Children and Harvard Medical School. He's an expert in caring for teens and young adults with addiction. Dr. Hadland, welcome back to the show.
Thank you for having me.
So, Scott, I know you've talked to us about this before, but can you sort of give us an overview of how prevalent opioid use disorder is among teens?
It's a really prevalent condition, and pediatricians are already caring for these young people. Opioid use disorder affects about 1 in 80 adolescents and young adults between the ages of 12 and 25. And opioid overdose is really common in this age group. In fact, it's now the third leading cause of death in all children under the age of 19. Our study found that among young people that we followed with opioid use disorder, 1 in 41 of them died during the 2-year follow-up period, which is an exceptionally high mortality rate and really concerning.
And as we get into the study, can you talk a little bit about buprenorphine and how this medication works to treat opioid use disorder?
Yeah, buprenorphine is recommended by the American Academy of Pediatrics for treating opioid use disorder in adolescents. It's FDA approved for ages 16 and older, sometimes used off-label in younger ages. We just have less clinical trial data available to turn to for that age group. And the way that it works is that when a young person is struggling with an opioid use disorder, when they stop using opioids, they experience really uncomfortable withdrawal symptoms and they experience strong cravings to use again. And those symptoms drive them to use opioids kind of repeatedly. And so we can break that cycle by giving a young person buprenorphine. Buprenorphine is an opioid agonist. It's a partial opioid agonist that binds to the opioid receptors throughout the body and relieves those symptoms of cravings and withdrawal, making it so that a young person can engage in their day-to-day life, go receive behavioral health services, get counseling, to go to school, to go to work, to engage with their friends and family.
We know that buprenorphine really helps adults with addiction, and it's approved for use under age 18. But what did we know about outcomes for adolescents before this study?
There are just a few studies looking at buprenorphine in young people, and that's why it's only FDA approved for 16 and older, is that there's actually just limited clinical trial data in adolescents. Now, there are a lot of observational studies that show that the medication buprenorphine and other medications, actually, if used off-label for younger ages, seem to be associated with enhanced retention and care, meaning that young people are coming back to see their clinician or their pediatrician and continuing to engage in their care. The studies from adults are even more powerful because they show that when adults with opioid use disorder get buprenorphine, it actually has a life-saving benefit, meaning that survival is improved in clinical trials and across studies. And, there's not that much of a difference between a 16-year-old and an 18-year-old when we're thinking about the biology here and the pharmacology. And so it makes sense that offering buprenorphine to young people is probably the right thing to do. And in fact, it's not just probably the right thing to do. The American Academy of Pediatrics endorses use of buprenorphine in this age group when young people are struggling.
So where did you go for data on how this medication is prescribed for young people?
Well, as a practicing pediatrician and as somebody who treats young people with opioid use disorder, even though we know that buprenorphine is important in this age group, there were these critical questions that came up all the time in my practice. So the first question was, how long do young people need to stay on medication, right? It's not common for young people to want to go on a medication and stay on it well beyond the period of time that they're starting to feel better. And then when they're on the medication, how adherent do they need to be with it? Do they need to take it every day? Can they get away with taking it every other day, or can they come on and off? And so these were two questions that really came up all the time in my practice. And so we turned to a data set called the PHD data set, or the Public Health Data Warehouse here in Massachusetts, which is this really critically important data set in our state that has all of the health insurance claims, both public and private health insurance claims of people all across the state, and then links them to other data sets across the state, including their receipt of addiction treatment, information on ambulances that might be out in the community and sort of addressing overdoses, vital statistics so that we can know if a young person has actually died of an overdose. And so we get this really complete look and information on young people who are struggling with opioid use disorder.
And when you looked at these prescriptions, how long were youth on the medication to treat their opioid use disorder?
Well, the approach that we took is we looked at prescription filling data and information from our prescription drug monitoring program that monitors distribution and prescribing of controlled substances across the state. So we used this really complete information to try to identify what patterns of duration and adherence do young people have with buprenorphine. And what we found is that if you looked over the course of a year after a young person started on buprenorphine, there were 4 groups that showed up in the data. The first group was young people who went on the medication for 12 months and stayed adherent to it, basically took it most of the time. There was another group that went on the medication for about 12 months, but kind of came on and off throughout the study, and so had lower adherence. There was a third group that stopped the medication after 3 to 9 months and just came off altogether. And then there was a fourth group that stopped the medication after only 3 months. And unfortunately, actually, as we'll discuss in a moment, because of the outcomes of these youth, this fourth group where people stopped quite early was actually the most common pattern that we observed. Only 24% of young people went on the medication for a year and then took it consistently.
And before we talk about those who discontinued the medication early, if they stayed on it for longer, did this help with things like subsequent visits to the emergency room or overdose?
Well, so that's exactly it. When we compared these 4 different groups, we actually saw the group that had by far and away much lower risk of having adverse outcomes were the young people who went on the medication for a year and stayed on it consistently for a year. Now, actually, as an important part of the study, we actually looked at their downstream health outcomes. So we didn't just focus on that first year that they were on the medication. We actually looked to see what happened during the year after that. So kind of months 13 through 24, if you will, and asked the question, what happened in terms of overdoses, emergency department visits, and hospitalizations? And the risk of overdose was significantly lower in that group that went on medication and stayed on it and took it consistently. And just generally speaking, the rates of emergency department visits and inpatient hospitalizations were also lower, and significantly so.
Now, we said that buprenorphine is the only medication authorized by the FDA to treat youths under age 18, but did you look at other medications that are used for opioid use disorder and what the outcomes were there?
Yeah, we did. The focus of this paper was really on buprenorphine. If you look across studies, when a young person has opioid use disorder, whether they're, 16 or older, or even if they're under 16, or even if they're over the age of 18, where there are other medications that are available from an FDA authorization perspective, buprenorphine is actually the most commonly started medication in the adolescent and young adult age range. It actually accounts for about 80% of medication usage in this age group. But we understood that some people might go on buprenorphine and decide to switch to a different medication. So there are 2 other FDA-approved medications. Those are methadone and naltrexone. But actually, we found that it was really sort of a minority of youth who switched to a different medication. We did include young people who switched to another medication and kind of considered them to be adherent if they continued to take that other medication.
And before people go and read your paper, what is one last takeaway you want to give listeners about buprenorphine for treatment of teens and young adults?
Well, I've got a few points. The first one is that many of us pediatricians are already caring for young people who have an opioid use disorder. As I mentioned, even in the 12 to 17-year-old age range, about 1 in 80 young people has an opioid use disorder. So we're already caring for these youth, and pediatricians can provide buprenorphine in their primary care and subspecialty practices. And I really would encourage listeners to consider this as being sort of routine and standard evidence-based care, not something that is specialized or niche or requires everybody to be referred out, and to really normalize going on medication and staying on medication because we know that it's truly life-saving.
I certainly hope our colleagues will take that advice. And Dr. Scott Hadland, thank you so much for joining us today.
Thank you for having me.
To read the paper, Buprenorphine Treatment Duration and Adherence Among Youth and Subsequent Health Outcomes, visit our website at aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, since I've been out of outpatient care for a while now, I miss people coming up to me in stores and in public and saying, Dr. Hill, you're my doctor. But I kept bumping into this mother and 2-month-old baby in the store last week. We were just going through at the same time. And being a pediatrician, I had to stop and compliment her on the baby and smile at him. And then Dad comes up and is like, hey, you were there for our delivery. You were our doctor in the hospital. And I'm like, oh my gosh, look at how big she is now. She's beautiful. And, those moments are rare for me anymore. And I just appreciate them all the more.
Wow, you really influenced my Say Ah, because there have been a few times where I'm working in the nursery and a friend or a friend of a friend delivers a baby. And it's crazy because I get to see them in the hospital right after the baby is born. And this happened with actually someone who wasn't a good friend of mine, and then we became really good friends. And what was really funny about that is, because I've known her for so many years now, she had saved her discharge summary from the hospital. And one day, years later, she showed it to me and said, "Do you remember examining my twins? Here's what you wrote." I was like, oh my goodness. I didn't know people actually kept these forever. Actually, I have all the ones for my kids, but wow, it's like such a privilege being a doctor sometimes. It's just wild.
It is a joy. Well, that's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next time when we'll bring you the December edition of First Up.
We'll speak to the editor-in-chief of Pediatrics, Dr. Alex Kemper. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.